Our keynote speaker for this afternoon is Dr. Robert Kushner. He is a professor of medicine at Northwestern University, Feinberg School of Medicine, and director for the Center for Lifestyle Medicine in Chicago. After finishing a residency in internal medicine at Northwestern University, he went on to complete a postgraduate fellowship in clinical nutrition and earned a master's degree in clinical nutrition and nutritional biology from the University of Chicago. Prof. Kushner is a past president of the Obesity Society, and he has headed a number of organizations. Professor Kushner has authored over 215 original articles. His most current book is Lifestyle Medicine, a Manual for Clinical Practice. Please welcome Professor Kushner, who will be presenting on lifestyle medicine and obesity medicine, preparing the 21st for the 21st century. Please welcome Professor Kushner.
Thank you. Thank you. All right, I'm going to do my best to get this up. Wonderful. Thank you, the organizers, for inviting me, particularly Dr. Chin, for the personal invitation and emails to help bring me here. So thank you very much. I truly enjoyed being with the trainees this morning. I admire the composure and professionalism while they were in the hot box and being just salted with questions and queries, and really admire you, and you have a great class of trainees, and looking forward to hearing the rest of the presentations later today. Sitting and listening to the trainees reminded me, and also being research day, of my own journey. I started medical school wanting to be a family medicine doctor and then an internist, and it reminds me of the opportunities and challenges you have to be aware of when you are going through training and developing your early career. I did a 6-week elective in nutrition at UC Davis in California, which was life-changing. It literally changed the trajectory. I'm not sure what to do. It literally changed the trajectory of my entire career with that 6-week exposure. It just, so keep your eyes open, look for mentors. Also, I remember that I applied for 2 CAM grants from the National Institute of Complementary Internal Medicine when I was younger. I didn't get either program grant. But if I did, I could just think about the trajectory my career would have gone in if I got that grant, but I didn't, so I went in a different direction. The talk I'm giving is one I have not given before, but I wanted to talk on this knowing I was talking at a university, assuming I'd be speaking in front of learners and educators who were responsible for educating our future physicians, and also regarding 2 career opportunities in medicine that were non-existent 5 or 10 years ago. It also reminds me that we're talking about research all the time here, but for those of you who are educators, remember there is research in education. And over the past decade or so, I've converted or shifted a lot of my time to not only education, but studying education and publishing in education. And I think it's a nice give back for those of us who are entering our senior years as educators and mentors to think about the next generation. So anyway, that's why I chose this particular topic for today. I have no disclosures. You've already seen that already. This is my outline. Why lifestyle medicine? Why obesity medicine? These are terms that many of you may not have heard of, but since the research topic is obesity, and we've heard so much about non-communicable diseases and population health, I wanted to organize that thinking for you that this actually is a career path now under a new name. We've heard of exercise medicine and addiction medicine. There are now 2 new directions with boards and so forth that coming up of those 2. Third is incorporating lifestyle medicine, obesity medicine into the medical curriculum. For those of you who are educators and those of you who are learners, I want to show you what we are doing at Northwestern to try to prepare our clinicians for the 21st century. And lastly, some of the work that myself and others are doing in progressing, advancing obesity medicine and where we're at regarding that. These are key facts from the World Health Organization. I literally copied them. I'm not going to read them to you. You can scan it yourself. But it's really just on one slide to demonstrate the importance of why we need to be thinking about a lifestyle to train our students because of non-communicable diseases, which you've all heard about. If we look at cardiovascular disease, cancer, respiratory disease, and diabetes, we really got what most of our patients are at least dying of or spending our resources. And accordingly, how we prevent those conditions is to help our patients through shared decision-making to help them reduce tobacco use, how to be more physically active, how to use alcohol in a very responsible way if they do it all, get physically active, as I've said, and choose healthier diets. If we could do those 4 things, we are going to help our patients tremendously. And of course, what we know is that students are woefully unprepared to really engage patients in how to change their health behaviors. I'm also going to show you 2 articles from the literature that just came out in the past 2 years. If you have not seen them, it's really a wonderful resource regarding global conditions. This happened to be DALYs, which is disability adjusted life years, for what is contributing to these problems. I just circled the Caribbean since that's where we are. I'm first struck mostly by, I guess the arrow does work. I'm mostly struck by what's called the unattributed area, which is like 50% or so, which reminds me that, it's not just our behaviors, right? It's genetics and behavior. It's the 2 together, which would be that unattributed area. But if you look on what can contribute to non-communicable diseases, blue really stands out to me, and that's behavioral. And behavioral is something we can work with our patients on because it's what they choose to do. It's how they live their life. So we can have a significant impact. And of course, there's others, metabolic, environmental exposures, and so on, which we could certainly look in our community, our environment, built environment, and so on, and exposures, other hazards. But really, behavior really jumps out as a major contributor to helping our patients be healthy. This is from the same paper. This looks along the y-axis, the individual exposures. You can see dietary factors. This is, I think, in women. There's another one in men. Dietary factors really jump out. And frankly, this is the kind of data that when I went into nutrition got me interested because I felt diet and nutrition was the leading cause of what I can do to help patients. I've subsequently transitioned into lifestyle and gone beyond that. And even if you look at the risk factors themselves, like high fasting blood sugar, hypertension, those themselves are impacted by behavior, as you know, physical activity, fruits and vegetables, physically active diet, body weight management, and so on. So this is where the action is. When I talk to students, although it's hard to get their attention because they're studying the Krebs cycle. When's the last time you talked about a Krebs cycle with patients, right? But that's what they're studying, and they need to know that. But really, when you get out there, they're not talking Krebs cycle with patients. They're talking about how can I eat healthy? Where do I find those foods? How can I eat in an affordable manner? How do I move my body around when I have 3 kids and I'm carpooling and I'm doing all these other responsibilities? That's really where we have a lot of impact to make. This is just one study, just to demonstrate. This is an older study, but it demonstrates it so well. This is the relative risk of incident diabetes among older individuals. So we had a talk earlier among older individuals, and what you see are the risk factors assessed in the survey: activity, diet score, never smoke, so forth. And what you see in the graph is that the more the healthy behaviors these individuals participated in, the lower the risk of getting diabetes within a 10-year period of time. So that those that had 5 or more risk factors, the occurrence of diabetes was significantly lower. 9 out of 10 new cases of diabetes were attributed to these factors. Just think if we talked to our patients just about this and reduced the risk of diabetes. The other thing that's striking is if you look at the individuals who had only 4 or 5 risk factors, that's at the bottom in the graph, you really only talk about 8% of people. No one had all 6 factors. So the occurrence of healthy behavior is a rarity. And that's demonstrated in this last slide regarding lifestyle medicine. This comes from NHANES. This data is a little old, but I think it's still relevant. NHANES 3 was like 1988 to 1992 or so, and then NHANES, the second NHANES is 2001, 2006. So what we looked, and NHANES, of course, is measurable. It's not just taking a survey. It's actually measurable. You're talking to them or doing these measurements. And what you see is the prevalence or the practice of don't smoke, they're not obese, fruits and vegetables, so on. And you see the prevalence in NHANES 3. A lot of Americans are not smoking now, but the prevalence of fruits and vegetables, physical activity, and alcohol are not all that great. So the overall practice of healthy behaviors around 1990 was 15% of Americans. Interestingly, when you go a decade later, the prevalence of these healthy behaviors drops, and now you have only 8% of the Americans practicing these healthy behaviors. So healthy behaviors is a rarity. So boy, there's an opportunity for us through population health, system-based medicine, individual care, community health, to really help individuals choose a healthier life. That's why lifestyle medicine, I think, lends itself to how we need to be educating our future doctors as well as practicing ourselves. What about obesity medicine? This came out recently in New England Journal. Again, if you haven't seen this, I would encourage you to do it. Again, it's Global Disability Adjusted Life Years. But it demonstrates, I think, so well. It compares the Disability Adjusted Life Years, or DALYs, on the top, deaths on the bottom. On the left is in the year 1990, and the right is the year 2015. And just shows in a very nice graphic presentation how the increase in death rates in DALYs have occurred in part due to the increased explosion or the syndemic of obesity, particularly cardiovascular disease. Cancer is also here, and your area of cancer is a big study in the United States on breast cancer and obesity going on, a multi-center trial. But obesity has a huge impact, and of course that's the whole point of our conversation today. This is the most recent data from the United States. You've already seen wonderful data from the Caribbean presented earlier, and there's ethnic and racial differences. Of course, America is more of a heterogeneous population, and you see more heterogeneous presentation of data because that's what America looks like. And what's particularly striking and incredibly alarming is the non-Hispanic black female, where 60% are classified as having obesity. And that really is the highest of all. Overall, it's about a third of Americans have obesity, and if you have obesity and overweight, it's about 65% of Americans. So as I tell students and when I do presentations, if you are not overweight or obese, you are now in a new minority. It's the non-obese, overweight minority. And it's really just incredibly mind-boggling how much obesity is a problem. And it's not just a matter of BMI and how I look in clothes. It's not a matter of vanity and cosmetics. It's an issue of health consequences. And I'm not going to go through these, of course, but obesity affects every single organ system. They used to say if you know syphilis, you know medicine. That was before my time. In my time, if you know diabetes, you know medicine. I will say if you know obesity, you know medicine. You know that saying, if you just study one disease, it affects every organ system. I think it's absolutely true with obesity. There isn't a single organ system that is not affected one way or another by excess body fat. And so that's why obesity medicine is so important. So how do you take these concepts and incorporate them in a university or a postgraduate setting? This is what we've done at Northwestern. I just want to show you how we are preparing our physicians for the 21st century. This is a quote from an article in 2010. Medical educators have been tasked with developing curricula to better prepare physicians to address the complex issues of the 21st century. In part, that's what this entire symposium is about, is how do we move forward using technology, novel interventions. Your entire presentation this morning was cell phone and forget the medical record. Just blow beyond that and think broadly. We need to think that way, and we're trying to do it in Northwestern to do it. Lifestyle medicine now is becoming a codified area with the American Society of Lifestyle Medicine curricula educators. I just threw a few headlines. A colleague of mine, Jeff Mechanic, had an opportunity to publish on this as well in 2015 as an emerging new discipline, kind of introducing this new concept of lifestyle medicine. I'm the director. I had a chance to name my new clinic quite some time ago, and I chose to name it the Center for Lifestyle Medicine. And that's foundationally what myself and my 10 collaborators do. We're registered dietitians, exercise specialists, health psychologists, physicians, nurse practitioner, physician assistant. All of us work collaboratively as a consultative service to help patients be healthier. What we do is we get a patient who's referred from another clinician, you know, with that referral card that says, lose weight, you know, eat healthy, get more physical activity. That's the prescription our service fills. We fill that prescription, like we're pharmacists. We fill that prescription and we guide patients on how to do it. So we define it as a new discipline that has recently emerged as a systematic approach for the prevention and management of chronic disease. The practice lifestyle medicine requires skills and competency in addressing multiple health behaviors and improving health management. That is not an easy prescription to fill. That cartoon I kind of like. We had a talk earlier about the resident about complementary medicine. I really consider it kind of plasma and chicken soup. That's kind of what we're doing. It's not alternative medicine. We just help people take better care of themselves. That's what the chicken soup is meant to convey. At Northwestern, we went through a curricular reorganization 5 years ago, so we don't have M1, M2, M3, M4 anymore. We now have what's called, I think it's in here, nope. Phase 1 is that very first chunk, which is the first 2 years of medical school, then Phase 2 and Phase 3, and there's various elements that are in here, which is health and none of that came out on this slide, unfortunately. Health and society, science and medicine, clinical medicine, that's what all these colors are meant to convey. But Phase 1 is the first 2 years, and I want you to know that because I'm going to come back and show you how we've introduced the concept of lifestyle medicine, obesity medicine during the first 2 years of medical school. We've also put in threads. Threads are areas of concentration that are sown throughout the curriculum. So I was fortunately at the table at the right time when the curriculum was being developed, and I said, you know what? We've got to get a thread in lifestyle medicine. And if I wasn't at the table, it's kind of a good point for all of you. If you're not sitting at the table, it ain't going to happen. So I was, at least myself, my colleagues were the champions that got lifestyle medicine as a thread 5 years ago, because we needed to train our students in that. So we were afraid it would get lost in the curriculum, so we worked with our design group at Northwestern to come up with a logo. Everyone needs a logo. So we came up with this logo that they helped us design, in which all of our material is flagged when the students see it. Oh, I get it. That's my flag. This is a lifestyle medicine topic. Otherwise, it would get diluted and they'd feel they graduated without any of it. And we decided to put obesity as a component within lifestyle medicine. That's how I look at it. Because when I help patients manage their weight, I'm talking about diet, physical activity, stress, sleep hygiene, how do you adhere to the things I'm talking about, all in a family structure and so on. So it's really lifestyle medicine. So we put it as a component of that. If we look at how we distribute lifestyle medicine during the first 2 years of medical school and all those components I talked about, that's what it is here. We actually have 489 sessions in the first 2 years of medical school that cover these topics, not solely. So for example, if there's a topic on breast cancer, there may be 1 or 2 slides on the role of obesity in cancer recurrence. So they're hearing, okay, obesity, breast cancer, there's a link there. It's not a whole topic on just obesity. It's how do you integrate it? And this is an example of how we integrate obesity within those modules. So we do it as adult learners. You want to teach it at the right time, at the right level. So for me to have a symposium on obesity, independent of all the other organ systems, is meaningless. The students will not make the connection. So we introduce topics of obesity in the number of sessions as it's most related to that topic. So you can see endocrinology and reproduction, which are towards the right, have the highest dose of obesity because that's where a lot of the obesity comes in. Endocrinology because of metabolism and appetite regulation and so on. Reproduction because of birth and programming and child rearing and so forth. I'm going to give you 2 other examples. It's almost like a fingerprint. If you look at diet and nutrition, it's different. It's in foundation, it's in renal because there's fluids and electrolytes and acid base. It's in GI because there's absorption of nutrients and vitamins and macronutrients and malabsorption. And then it's also in heme for nutritional anemias. And another example would be physical activity, which is scattered throughout as well. So the students are learning lifestyle medicine topics that's integrated with the rest of their curriculum. That's how we are educating physicians for the 21st century. So when they graduate and they see someone with a GI disorder, they're thinking, okay, what nutritional or what lifestyle issues do I need to be thinking about when I have a patient who comes in with GERD or with fatty liver disease or with diarrhea, that kind of a thing. We also have exposures in the community. This is called Keep Your Heart Healthy, where students actually go out and have a practicum on doing health screening, taking a blood pressure, talking about salt intake, talking about physical activity, cigarette smoking, and so forth. So it's a wonderful way for students earlier in their career to work within their community. And lastly, and most recently, we developed a culinary arts elective where students are learning to cook and touch food and heal with food, and they actually then go into the Chicago school system and do topics with students. I'm going to end with progress in advancing obesity medicine. This is where I've spent a lot of my most recent time in developing a kind of a longitudinal approach to how do we advocate and push forward obesity medicine. I think of it as a top-bottom areas of education and what we need to do. The very top is to create a subspecialty or focused practice in obesity medicine. In other words, if you are a resident or you're early in your career and you've decided that obesity is one of the most important things that you want to do, and you want to develop an identity and competency in obesity, where do I go? Where do I get that competency? And that's why we developed the American Board of Obesity Medicine in order to create a home for clinicians who want to spend a fair amount of their time doing obesity medicine. The whole idea, the whole saying, if you build it, will they come, we actually were thrilled to see that. Within the past 5 years, these are the number of obesity medicine diplomats who are taking CME, passing an examination. We now, within 5 years, have over 2,000 diplomats within just the first 5 years. And you know what? They're primarily coming from family medicine and internal medicine. Those are the clinicians, the ones on the front line doing primary care, who say, I need a higher level of competency in order to tackle the patients with obesity that are coming in, because that's the problem, the primary problem I'm seeing. CME is exactly what we're doing now. That doesn't need to say anymore. Another area we worked on is if you want students to learn about obesity, it's got to be assessed. Assessment drives learning. Teachers don't like to say it, but it's true. Assessment drives learning. Why is it? Because the students will ask you, is it going to be on the test? And if it's going to be on the test, they learn it. That's why assessment drives learning. We went to the home of assessment, the USMLE. That's a licensure exam, step 1, 2, and 3, to find out, is obesity on the exam? And we published that, and you guys can go search this stuff later yourself. So we were invited in for a day and a half in Philadelphia at the MBME, which does the USMLE, to see, is obesity on the exam? You know what? It was not. They were still asking questions like, I don't know, obesity is defined by what BMI? I mean, just really nothing type of stuff. So what we actually gave them and submitted to them is, this is what was missing. Just look at this list. I'm not going to read it to you. This is what was not on the exam. For students coming out of medical school today, they are not being tested on any of this. This is modern obesity medicine. And to their credit, they are now putting people with obesity training on their committees to help write items because of the activity that we did. The last thing we're doing, and I'll just leave you with this, is now we are developing competencies and trustable professional activities for obesity as a turnkey operation. And when they're done, this university, for example, could take these competencies that have benchmarks and put them right into the curriculum for undergraduate, graduate, and fellowship training. This is currently work in progress. So the takeaway themes: healthy lifestyle behaviors are enormously important in preventing the occurrence of chronic disease. Obesity continues to be a major national global challenge and risk factor for morbidity and mortality. Physicians practicing in the 21st century must develop a competency in lifestyle and obesity medicine. It is incumbent upon medical educators to incorporate these topic areas into the curriculum. Thank you.
We're open up to some questions.
fascinating. I'm intrigued by the medical education component. What I want to ask, you can't hear me, no? Okay. In the same way in which psychology evolved in the treatment of mental conditions as psychiatry, why do I need to do all of this medicine if my primary focus is on lifestyle and aging? Why do I need to be a doctor if that's what I want to do?
Being a physician provides an incredible perspective and all-around knowledge that I bring to my team that my dietitian, exercise specialists, and health psychologists do not have. I can put lifestyle in perspective. I could prioritize. I can guide the patient as it relates to them. It's like that personalized medicine or precision medicine. So I'm not going to tell everyone to achieve the same physical activity, follow the same diet. I may say something about cigarette smoking and alcohol because that's more, risk factors with substance use. But when it comes to how do you take yourself, are you single, are you married, what's your commute time, what's your family structure, what's your family history, I can do that better than anyone else on my team because I'm a physician. And you know what? There's also kind of a respect, I guess, that comes with the badge. If my doctor's talking to me how important diet is, it just really has a huge impact. That's the power of communication.
How do you know that?
What she asked a question. Say it again. One sec.
The question is, how do you really know that?
How do I know what?
That physician, that because you're a doctor, that badge
Yeah.
of respect means that somehow
Yeah.
that lands differently.
So the question is, how do I know that being a doctor has impact? Because studies and surveys have shown that. And there's one very important one in obesity, since this is the topic today. There's a study using NHANES where there's they call them up and exit interviews type of thing, that if your doctor just told you, mentioned your weight, you're more likely to think of yourself that I have a weight problem. If your doctor also brought up your weight, you're more likely to do something about it. So that's just one of many studies with obesity. There are others with drinking and alcohol and so forth. Now, is it durable? Is it lifelong? Probably not. But in the moment, during that time, they're more thoughtful about their health risk.
Yes, Professor. Could you just tell me what you think is the reason for that quite dramatic decline in the percentage of healthy lifestyles in the United States in a single decade?
Yeah,
From
so-
15 to 8, half as much.
Yeah, so there's I only showed you one of multiple studies which we all call the rarity of good health. That's what we call it. And that's actually one of the highest percentages. Others are 3% and 4%. The only way and your question specifically, why the reduction when the methodology is actually the same, it's all NHANES and so forth. I think it's secular changes. I think the healthy thing to do is the harder thing to do. I think it's even getting harder. I heard some conversation about a normative effect of obesity. I think that is also true. I think the whole women's clothes size is 0 20 years ago is not 0 today, right? They're changing because of secular changes in all that. So I think it's really the cultural and secular change in the United States. It is hard to be healthy. And there's less and less opportunities to be healthy on a daily basis. That's my interpretation. I don't think anyone actually can. That's my interpretation.
Last question.
I noticed a marked difference in the Asian population. Did I see that correctly? Can you explain in obesity prevalence?
Yes.
How do you explain that, and what is that group
Yeah.
doing? They're in the same environment, the obesogenic environment.
Right.
So
Well,
is it a cultural difference, genetic, and
So I think the difference in incidence and prevalence of obesity among ethnic and racial groups is I think, well, it's multiple things. One is genetics. And Larry Cheskin earlier talked about how obesity is now defined at a lower BMI and a lower waist circumference because genetically they're unable to tolerate the excess fat that some of us may do as Caucasians, and particularly where they're actually have it on. But you certainly can't disregard the cultural differences, the secular difference. The whole, if you actually go into various communities and ask what's your definition of health, right? One is taking care of my grandson, another one is hip-hop dancing, another is I look great in a dress in a mirror, right? So the whole definition of health varies. So I think it's genetics and culture.
Thank you, Prof. Our next speaker is Professor Desiree Cox, who is considered a multi-gifted, successful woman, not only in her chosen academic field, but also in visual art, writing, and singing. She is the first Bahamian to win a Rhodes Scholarship and the first female British Caribbean Rhodes Scholar. She has been a guest lecturer at both Oxford and Cambridge universities, as well as many top-tier universities, such as Rutgers University. Please welcome Professor Desiree Cox, who will do a presentation on the CCC study.
Yeah, I was recently at a conference where a colleague put this medical humanities conference at, in Kalamazoo, where a colleague put that really well using one of these PCs. He said, I haven't been familiar with this interface for some time, so hence my twiddling around. So earlier this morning, I talked about the incubator, the HeLink incubator, as a model for incubating ideas and creating knowledge. And I mentioned at that time that there are specific studies that we actually did. I gave a taster of one of them, and this presentation is about goes into details with one of the other studies that we did out of that incubator. It is work done by myself and Dr. Calais Philippe, who isn't here, but she tells me that she's watching by webinar, and I'll explain that as we go on. So it's a joint study. So these are the areas I'm going to touch. I'm going to touch a bit on the background to why we did this work, and this is growing on from the earlier session this morning, in which I want to drill down on the importance of methodology, and so our methodology around this, and the history of it. I'll talk a bit about using the incubator to kickstart that work and how that played out in this particular study. And the reason I'm doing that is because of the challenges and the barriers, and that was pointed out by many of the speakers this morning, to actually getting research off the ground, having it be sustained and maintained, having it be relevant, and having it integrated into actual practice and not sit off somewhere on the side. And then I'll go into some of the research findings from the CCC study itself. So let's just go straight here. So this work began because Dr. Philippe had been working with a group of people on the discharge planning committee. She came to me to ask me about mentoring her, and my response was, well, great, but I need you to be doing something. I need it to be concrete that you're actually mentoring. What are you actually working on? And she shared with me this discharge planning committee process. You heard from me this morning a version of the fact that for me, committees feel to me like my brain has been dropped in a vat of concrete. And so when she described to me this arduous committee process gone from 2009 to 2015, and they had reviewed all of the discharge planning documents from all of the hospitals, this was the sum of what she'd found. Readmissions were up, avoidable hospital admissions were high, patient dissatisfaction, disorganized patient flow processes, lack of communication between healthcare institutes, poor quality of care because the right information was not getting to the right people at the right time, lack of continuity of care, poor outcomes of patients. However, really, although there were these successes, they had harmonized, they had a harmonization committee, and they'd pull together all these policies. They had recommendations for how to move forward, and they'd done a small baseline study of, I think, about 10 or 15 patients at PMH. The real challenges were dwindling interest, and you can imagine a process that's gone on for 6 years would cause that. The stagnation of, at the committee levels, bureaucracy and silos, and so these are huge barriers to getting past the work that they had done, and limited impact within these institutions. So and I come to this phrase which I often use, which is you can't solve the problem at the level of consciousness that it got created at. So when I heard her describe this process to me, for me, what I heard was a process in need of some serious creative disruption. And one of the challenges here is that a lot of good work gets stuck in a rut because of these outdated processes. There's huge disengagement in healthcare among healthcare professionals. Healthcare professionals said to us, we don't feel anyone cares about us, and we don't feel really appreciated for the work we do. And over time, this leads to burnout. We know from the data in the US as well as here, the data is better in the US, there's a huge percentage of burnout. A study once described to me, reported that it costs about $250,000 to train a physician. So when that physician drops out, you just think of the waste of that. So when looking at cost effectiveness, a huge part of the conversation that gets left out of this is the waste that happens as a result of burnout. There's also, so I mentioned that it's expensive, and so we wanted to take a whole person approach. When you're looking at research and you're looking at intervention and champions, I think too little attention is placed on people and engaging people at the level of the wide range of their talents. Their talents may not just be for that box of a job that they work in, may extend beyond that. So if you really want to do research that is going to be health quality improvement, you have to find a way to engage people more broadly, and you get a much better result as a result of that. So our disruptive approach, as I touched on earlier, and I'll just touch on it now, I mentioned the model in more detail this morning, involves a kind of incubator-like space for innovation, uses an R&D strategy for improvement. So great ideas, you need metrics around that, so we think about metrics around that. We look at mentors mentoring other mentors, so there's not just a top-down approach in that sense, but you're mentoring your other colleagues. And we look at high-quality execution, which is not a strength in the Bahamas. You have a lot of last-minute stuff. At the last minute, a kind of last-minute urgent rush to get it out. But in terms of high-quality, sustained intervention, that's a muscle that culturally we could do with working on, and linking research to passion projects. So those were conceptually what we did. So I'm going to go through now the components of the design, the methodology. I draw on Peter Drucker's expression, if you can't measure it, you can't improve it. You have to find a way to measure these components. So the objectives are research questions. Objectives were as follows. Discharge planning is traditionally seen as the nurse's job. Okay, and so physicians often are not terribly interested in that. They don't really, it's not polite to express the extent to which they're not interested, but it's clear that they don't see that as their priority. So our question was, what does it actually mean? What are the gaps? What percentage of doctors are actually asking patients about the discharge planning and what happens next? What's the patient's experience? What's the level of satisfaction? How many of the patients are actually seeking care, who come into hospital actually need to be there, avoidable hospital admission? admissions, and also are patients leaving with the proper discharge documents, and why do you need to actually even address those problems? Those were our broad areas. We could not work on all of those things at once, but I mentioned all of them because it's important if you're looking at where you're going to start the work, what's the bigger landscape that what's the whole picture, and therefore where are you actually going to start? And you need to actually take the whole picture in mind, not just work on some tiny strand of it without the big picture in mind. So this gives you a kind of graphical landscape of the components that we looked at. The circle captures the key components of the study we actually did. But we wanted to bear in mind this importance of activated patients. We wanted to keep in mind the social determinants of health, and really about 80% of your health is shaped by them. We wanted to think of what we were doing as creating learning systems and an integrated approach to monitoring and evaluation that was also modern. And so we made a key decision that this would be a paperless study. So the design components involve this ideal discharge planning guidance. We took the guidance and we used it as a part of a tool. We also created a patient satisfaction baseline questionnaire that really would be digital, and you would be able to apply that in any hospital. And so we were looking, although we were developing a prototype and trying it out in Grand Bahama, a prototype that could be adapted for any of the healthcare institutions in the Bahamas. The third component was based on a PAHO guidance document of avoidable hospital admissions. We converted that into a digital tool, drawing on the PAHO admissions, and we created it as a PAHO admissions tool. And the fourth component was this business of activated providers. So the idea here was to crowdsource from within the institution to find researchers. There's a complaint that there aren't enough people interested in research, that there aren't enough full-time researchers, it's going to cost a lot. So our sense was, what if the people who are delivering care have knowledge about this discharge planning process and how their systems work that's nascent, that they're not even sure that they have knowledge of? What if they are the experts, and you don't need to get a group of consultants or a group of external researchers to do that work? And if that is so, would not that resource live not just within physicians, but within ambulance drivers, within nurses, within dietitians? What if they were also your researchers? And so that was a key process of this activated provider. So we trained about 40 observers. The key was to actually have people step outside of their preconceived notions of how things must go and how they go, to become observers of their system. We selected about 20 of those observers. We made sure it was a diverse group, so we had ambulance drivers, social workers, dietitians, nurses, doctors, all acting as observers, and all using the same filtered and same template for which to do that observation. We had them use modern networks, so they were connected through WhatsApp on a daily basis when that study was following. They created their own subgroups within that so that they made it competitive and fun. And then we pulled those together. So I've described to you the design components. If you were to describe this, if you were writing a paper, you would see this as a mixed methodological observational study, real-world study, looking at a population of about 500 patients and their family members. This was the age range. It occurred over a 8-week period, so 2 months, with patients who were a select group of patients who were passing through A&E and who were through the medical and surgical wards. We picked the Rand Hospital. It was a more contained system, and we would have access to the public health clinics. They're all a part of one umbrella, so it was strategic in terms of the system of the country, but we had the whole country in mind. When it came to the practical business of doing this, we gave patients, the 40 observers, the 20 observers rather, the 40 trained, an iPad. They walked around the hospital with all of the data coded on an iPad. They were able to do their interviews with patients with their with this interface. That data was immediately passed on to the server, which is a Public Hospitals Authority, and so we in Nassau could be doing managing a lot of the process from Nassau, but seeing the data and hopping over to Freeport and Grand Bahama to see how the process was going. They came up with this term of the patient experience from hello to goodbye, that really effectively, if you took that label of discharge planning out of the picture and you looked at what you were actually trying to look at, what you're trying to look at is information flow from when the patient enters the system to when they leave. And so that is from hello to goodbye. And what if, instead of discharge planning being that thing you do 10 minutes before the patient's about to go and there's a scurry that there needs to be some paperwork to hand on to the primary care physician, what if you saw that as a process that began when the patient entered the system, and you saw that in terms of information flow? Then it's not something that just doctors do or nurses do. It's something that clearly everyone who touches the patient is involved in. So we reframed the concept of discharge planning with the root group, the aim of re-educating people in this new picture, again, to make sure everyone was engaged. We divided into 3 phases. The hello phase is the risk assessment completion, identification of the caregivers at home. The how are you doing phase is that middle phase when you're reviewing the instructions, you're scheduling planning meetings, you're discussing questions with family, you're consulting on the team about management, you're distributing that checklist, the booklet, so that people and patients and families in particular are prepared to ask the right questions during the hospital stay and not just at the end. And you're seeing that last phase, that goodbye, as a reconciliation phase rather than just beginning the process. So what did we see in terms of results? That should be a slash after the R. The idea is when you're looking at something like this, collecting data, you should see it as patterns. Those patterns are a window, not just into the brain of an individual, but also a window into hacking into the mind of the system. What we saw, and this is just touching on the demographic results, we saw that a vast majority of patients who passed through the hospital during those 2 months were women. We wanted to point out when we presented this data to the physicians and the people and the nurses and doctors, because the important thing is to give them back their data, is to try and trigger their senses of the implications of that. If women who are the primary caregivers are in hospital, what's happening to those children at home? So it's not just the democracy of the distribution of gender. The question is, what is the implication of that piece of data? We also pointed to, in terms of service utilization, that if you were thinking of now how you're going to upgrade the system, one thing that this starts to show you is the bulk of the flow within hospitals. Not surprising, because impressionistically this is what you would see, but it's important to have some sort of data baseline as to how much time people are spending in different parts of the hospital. We also wanted to point out to provider interactions, and we wanted to point this out particularly in terms of this preconception of the information flow. That actually, if you look at the key interactions, this was from the data that they collected, 72% of the interactions that are relevant to the discharge process are physician-based interactions. We could, using the patient satisfaction data, and I won't go into detail, determine which wards patients thought were great, how people were doing, and we thought this could be a useful way if you were looking at your activated providers now becoming champions of change, that the activated providers could use this kind of very shorthand way of seeing how the ward was doing, and that could trigger the kind of competitive work to improve the work on your ward. The avoidable hospital admissions is an interesting story. Whereas the data, the providers collected showed this distribution. When providers reflected on what they considered from their clinical point of view as avoidable, in their opinion, something like, I'll find that graph, the 85, 87%, as far as they were concerned, of people of the admissions in hospital were actually avoidable hospital admissions. So we broke that data into these component stages 1, 2, and 3, and I'm just going to touch on a couple of things that are striking that we're doing in hospitals and that's useful to note. And I'll just focus on the physicians, but we could break this down for nurses as well. That while it's clear that most physicians are doing really well at addressing and discussing patients' questions, I want you to notice how not great they're doing, and this is not just physicians, the nurses' data is very similar, at family questions. So it's still kind of seeing this patient as a separate thing disconnected to their family. And so there's a recognition that more work could be doing that. There's also this sense of, it's not really my job to give out the questionnaire and the checklist and the booklet and the explanation to family, that someone else could do that. And so if you're looking at an integrated system, what if everyone took it as their responsibility to make sure that the patient was aware, patient and family was aware of the entire process? So that isn't just left to one person. When you're having the interaction, you're also leaving the patient with some way of communicating with you and asking questions afterwards. We also want to notice this business of scheduling the discharge planning meeting, and there's an interesting graph on that at the end to point to, is when you look at the stage 3, or just look at all the data, but look at that 7 and 9% arranged any home care needed. That basically the data is showing that at that point, you're just pushing them out of the door. Please go. Go, go, I'm done with you, and there's not really the kind of attention to making sure the link happens. Again, some of this isn't surprising to people, but it's important if you're looking at change. You've done one thing, which is activated providers, but you've also created the baseline data that they can now measure from moving forward. The final thing I want to point to in terms of the results, and I want you to really sink in the implications of this, is when it came to the sorts of things people left hospital with. Of the 500 patients, there was something like 975 different types of bits of paper they left with. So nothing was standardized, which means that I left with anything from a scrap of paper saying with an appointment to an illegible script to take to the pharmacist, to a couple of handwritten scribbly things to hand on to the family practitioner, to a sort of sick certificate. There was really no standardization. So when you're looking at the link, the follow-up, the continuity of care, this data really produced some pretty damning information. And what's important here, it's important in terms of next steps, is because the providers, activated providers, have captured this in their observation. The study is therefore not just research and data, it's a process of activation for them. So they're taking responsibility of that. They're somehow shocked and surprised. Oh my God, I didn't realize it was that bad. We've really got to fix that. So you've also increased and improved the level of debate that group can have about improving their system. So I say the strengths and weaknesses, and we don't really have time for that. But I really, in terms of just moving on to questions, it's important when you're thinking of designing studies that are about quality and health improvement that you're also looking at why you're doing it. And you're building in those components into the design. You're building in next steps into the design. And you're considering not just the people who are collecting that data and doing the research for stage 1. You're looking at who's going to do the work afterwards, who's engaged, and so that to build in mechanisms of engagement for long-term work into the study design is critical. And exciting for me, all this data was now digital, and now no paper allows you to easily move forward with next steps. So that's it.
is such an important topic, such a vexing issue, and there's so much information. I think that we can allow 2 questions. Any questions? Okay. 1 question, and we'll close. Yes.
You said that 19% of persons were leaving hospital without a discharge summary. I want to know which departments that were, because if it was actually an emergency, for example, you will expect them to have less discharge summaries. But if you're coming from medicine or surgery, we know for a fact that the nurses will call you and say, you know, a summary is not here for this patient. Can you come and have that done to complete the process?
Yes, thank you very much for that question. So one of the reasons we engaged people in the system to be observers was because when we began to try and collect the baseline data by asking people exactly what happens, they all took their entrenched positions in the way you're describing. It doesn't work like that. It's got to be 70 to 80% of the time, because I'm always called about the discharge planning process. So people defended their position, and what was palpable was that they actually got to make the distinction between what they think is the way it works and what the data was showing them is the way that it plays out, and that could then show them the gaps. And so it's not blame and finger pointing. The data is giving them the awareness. You know, actually, this process doesn't work as well as I like to say it works, and maybe there are areas to fix. And it's very hard to elicit that within the group of healthcare providers who've been maybe working in that institution for 20 or 30 years and are quite invested in the systems that are in place. So this work was particularly powerful for me because people then stopped the blaming. They were a part of the solution by being a part of the data collection.
Professor Cox, you know, taking a cue from your morning presentation when we said that instead of going incremental, why not go exponential? So why go back to this incremental level of having this? Why not use the same smartphone, smart data, where you put it up on an app which is accessible to everybody, but based on the amount of your involvement in it, you can access your data, or the health provider accesses their data, and it is accessible all over the place?
That's a really excellent question. So that's really where my brain was right from the beginning of this process. And when I did my sensing and testing of the environment, I thought, well, okay, Desiree, that may be where you are, but there's going to be a journey, okay? So we need to take our people on a journey so that there's not the pushback towards that kind of thing. And we really saw this as a journey. So just having the study work was a huge journey. Many people at the higher level said it couldn't happen, it shouldn't happen, but the reality is once they were part of making it happen, they saw that those barriers went down. So I agree. The next step, as you're pointing to, is scalability. So what's the next step in terms of scalability? I think the next step in terms of scalability is definitely exponential. I do not think that has to be really expensive, but there are some embedded systems we have that relate to what the Americans describe as their kind of HIPAA compliance, and we don't really have that technically here, but we have versions of that here. There are those barriers that you've got to look at navigating for patients to have secure access to the data, and that privacy issues are really dealt with in that conversation, and that it's truly accessible. And also, that means you've got to communicate data in a very different way than we communicate these graphs and whatever. They're not really user-friendly, so we've got to think of how to communicate the data for patients. So I think that's really the next step, and I don't think we should. I think anything less than that really is putting us a step back. And I think we have the potential in terms of ubiquitous connection in the Bahamas geographically to use that as a way of closing the equity gap in terms of geography for us as well.
Thank you, Prof.
Thank you.
Okay, so we're going to get into some of our residence papers, and The first one up is on descriptive epidemiology of patients with acute ischemic stroke who were thrombolized having met the criteria at Princess Margaret Hospital. Please invite resident of medicine, internal medicine, Candice Bannister. Dr. Bannister.
Okay, good afternoon. The title of my study is Descriptive Epidemiology of Patients with Acute Ischemic Stroke who were thrombolized having met the criteria at the Princess Margaret Hospital. I have no disclosures. So the incidence of cerebral vascular accidents is becoming an ever-increasing problem within the Bahamas. It is one of the leading causes of long-term disability within the region and an increasing economic burden on the healthcare system. From 2000 to 2016, there were 270 cases of acute ischemic stroke documented at Princess Margaret Hospital. 231 of these cases were Bahamians. Thrombolytic therapy is the treatment of choice for acute ischemic stroke and is associated with improved outcomes. Thrombolysis improves chances of independent recovery from stroke, but its effectiveness is heavily time-driven. Studies have determined that thrombolysis to be effective up to 4.5 hours after symptom onset and is twice as great if given within 90 minutes. Despite the benefits, achieving high rates has been difficult. So there are many barriers that exist in patients receiving thrombolysis. It's narrow treatment window. It requires a multidisciplinary approach. Often there are delays in stroke recognition, delays in obtaining and interpreting radiological imaging, delays in obtaining consent, and physicians' uncertainty about administering thrombolytic therapy. So this study is important since there is no local data determining the proportion of patients who meet the criteria for thrombolysis in acute ischemic stroke in the Bahamas. Based upon literature review, there is still need for further research. So the aim of this study was to determine the percentage of patients with acute ischemic stroke who were thrombolyzed having met the criteria at PMH. The objectives were as follows: to describe the medical socio-demographic characteristics of those patients, to determine the proportion of patients that had an ischemic stroke, to determine the time within the patients with acute ischemic stroke arrived to the emergency room at the Princess Margaret Hospital, to determine the time between all points of care in the emergency room, and to determine the proportion of patients actually thrombolyzed. So it was a retrospective chart review of the medical records at PMH. All adult patients, it included all adult patients presenting to PMH with acute ischemic stroke between the 9th of January 2014 to the 23rd of October 2016. The inclusion criteria were those presenting within 4.5 hours of symptom onset. They had to have measurable diagnosis of acute ischemic stroke and age greater than 18. And this is the exclusion criteria. So the results, so the medical records regarding patients with acute ischemic stroke between the period of 2014 and 16 were found for 34 adult patients. So 55.9% of these patients were female and 44.1% were male. 67 point, so the mean, the mean age was 67.68. And most of the patients, 76.5%, were Bahamian, 17.7% were Haitian. Most patients were retired, 52.9%. And the duration patients spent at points of encounter with care. So the median time from symptom onset to the arrival at the emergency department was 10 hours. 6.3% of the participants arrived within 30 minutes, 34.4% arrived within 2 hours, 37.5% arrived within 3 hours, and 43.5% arrived within 3.5 hours. No one arrived between 3.5 and 4.5 hours. The remainder, 56.5%, arrived between 7 hours and 504 days. One of the patients arrived 3 weeks after onset of symptoms. So the mean time from being registered to being triaged was 33 minutes. The minimum for this variable was 13.2 minutes, and the maximum was 72 minutes. Their mean time from being triaged by a nurse to being seen by an emergency room physician was 2.7 hours, with a minimum of 20 minutes and maximum being 9 hours. For the 12 participants whose time from symptom onset to arrival was less than 3 hours, the mean time from registration to triage was 29 minutes, the minimum was 13.2 minutes, and the maximum was 58 minutes. Their median time from being triaged by a nurse to being seen by an emergency room physician was 2.79 hours, with the minimum of 20 minutes and the maximum being 8.5 hours. The mean time from arriving at the door to getting a CT scan of the brain was 6.83 hours, the minimum being 1.5 hours and the maximum being 13 hours. The median door to physician time was 2.3 hours, with the minimum time of being 48 minutes and maximum time of 10 hours. For the 11 who had arrived within 2 hours of the onset of symptoms, their median time from arrival to being seen by a physician was 3.58 hours, with the minimum being 1 hour and the maximum being 9.47 hours. The median time from onset of symptoms to getting a CT scan was 14 hours, the minimum 2.5 hours, and the maximum 506 hours. The median time from seeing a physician to getting a CT scan was 2.8 hours, the minimum being less than 15 minutes, and the maximum being 13 hours. For the 11 who had arrived within 2 hours of symptom onset, the time from being seen by a physician to getting a CT was 3.72 hours, with the minimum being 30 minutes and the maximum being 10.93 hours. The mean time from arriving at the door to getting a CT was 7 hours, then the minimum being 1.5 hours and maximum 14 hours. And most patients were hypertensive and diabetic. So, acute ischemic stroke remains the major cause of death and morbidity in the Bahamas, resulting in a major burden being placed in the healthcare system. The cornerstone of successful thrombolytic therapy in acute ischemic stroke is early recognition and treatment. A multidisciplinary task requiring appropriate neurologic evaluation and imaging is paramount. Coordination between EMS, triage nurses, emergency room physicians, internists, and accessibility to a neurologist is necessary. On the premise that time is brain, this has to be done in a timely fashion. It was clear that compared to the guidelines, patients were not seen in a timely manner. This grossly showed that patients are not receiving standard acute stroke care. There were multiple obstacles to patients receiving thrombolysis in this study, which is evident by the fact that no eligible patients were thrombolyzed. And all the patients that were, 43% of the patients that, 43% of these patients actually presented within the 4.5 hours, and they were all eligible for thrombolysis. However, because of these obstacles, none were. The issues encountered were at all levels of care, whether it was due to patient or institutional factors. According to the American Heart Association, American Stroke Association, guidelines recommends a door-to-physician time of being 15 minutes. However, the median door-to-physician time was 2.35 hours, which was significantly higher than the recommended guidelines. The minimum time a patient was seen by a physician on arrival was 30 minutes. However, this patient did not receive imaging until 12 hours later. The mean time from arriving at the door to getting a CT was 7.02 hours, which was significantly higher than the recommended of 45 minutes. The minimum time for door to imaging was 1.5 hours, which was still much more than the recommended time. This highlights that there are limitations to being imaged within the specified time at PMH. An astonishing 43% arrived within 3.5 hours of symptom onset. However, none were thrombolyzed. More alarming was that all patients that arrived to the emergency room within the window period had no contraindications to thrombolysis. So the question is, where does the problem really lie? The study showed that the burden is a result of both patient and institutional factors. Patient factors played a significant role in lack of thrombolysis. The study revealed that greater than 50% of patients did not arrive to the hospital within 4.5 hours of symptom onset. These delays were due to an overwhelmed ambulance system, lack of transportation, EMS not prioritizing stroke patients, physical inability, or lack of stroke symptom awareness. The institutional factors were inappropriate triage, poor recognition of stroke symptoms, an overwhelmed healthcare system resulting in significantly longer wait times in our emergency room due to a high patient burden combined with a lack of staff. This may hinder prioritization of stroke patients. So my recommendations: with the understanding that time is brain, it is important that patients are educated on stroke symptoms. Public announcements and community programs should be implemented on stroke symptoms and the importance of seeking prompt medical attention. A study by Quinn et al. 2008 showed that by educating emergency room staff, thrombolysis rates actually increased from 4.7% to 21%. Implementation of a stroke protocol and team would also be necessary. This integrates a multidisciplinary group of persons that will include EMS nurses, emergency room physicians, internists, neurologists, and radiologists. Studies show that stroke patients have better outcomes when managed in a stroke unit. Pre-hospital care also plays an important role in a patient outcome by improving thrombolysis rates. So the PASS protocol, this is actually used in multiple centers, and it actually involves connecting EMS drivers with internists, with the emergency room personnel, and with the radiologists. And this resulted in reduced delay at all areas of triage, thereby leading to higher rates of thrombolysis. And also implementing telemedicine units. The need for additional staffing is imperative. Public Hospital Authority, along with the government, may need to prioritize using more of the budget on hiring, purchasing of additional imaging machines, and maintenance, expanded the emergency room and radiology department. So in conclusion, just under half of the patients in this study met the criteria for thrombolysis. However, none were seen in a timely manner at all points of care, therefore not given TPA. There must be implementation of a multidisciplinary stroke team and protocol in coordination with the public awareness of stroke symptoms. So thank you. These are my references. I welcome any questions.
Okay, we're going to entertain 3 questions. Dr. Magnus.
Thank you, Dr. Bannister. That's an excellent presentation.
Thank you.
I must tell you, I enjoyed it. Number one, I have to congratulate you for trying to highlight this problem. I believe it's a public announcement. The statistics for stroke in the Bahamas has risen for 25% in the past 20 years. And I have a couple of studies, if you Google it, you can find it out, that is really hemorrhagic stroke is actually as high as ischemic stroke. It's supposed to be 25% out of the whole stroke. Having said that, Doctors Hospital have a stroke team. They meet every Wednesday. They plan it, they give TPA for everybody who require it. But to elaborate 2 points I have to make since I'm here. Number one, TPA, you have to be careful. Tissue thromboplastin activator. It's a protein enzyme, it's a catalyst, it's a clot buster, that's what they call it. What it does is activates the prothrombin to thrombin, which is factor 8. So what people have to understand is the standard of care for ischemic stroke that is not aggressively large is TPA. If you're not giving TPA, you're not giving the standard of care. And you have to have a conference meeting, tell the family members that you're going to get a TPA. And you're going to have a neurosurgeon on call. It's not a neurosurgeon in Lutra, because 25% of TPA will bleed. And you have to have an ICU handy, so that when they bleed, you got to attack. So consequential to that, you need to, I hope we haven't done one TPA in PMH from what you said. From what is recommended is 3 hours. If you have 3 hours window, I have gone as far as 4 hours, but 3 hours window, if you have that sign of neurological emergency, you have to give TPA. The dose is recommended. You have to go on a lower dose. For middle cerebral artery territory, which is a TPA that covers almost half of your brain, stroke, is recommended to hold TPA unless you're sure, because it can convert to hemorrhagic transformation because it's such a large volume. But there's no question this topic is so important. I recommend that you probably publish this work. You will refine a couple of things, like I need to know the statistics. What is it? How many people that will require that TPA that did not require the TPA? Number one. Number two, what is the dose recommended for the TPA? Number three, all doctors have to know how to read a CT scan. That's one of the solutions. They do a scan, they wait for radiologists for 6 hours to report it. The window is gone. And any emergency physician should know exactly how to read the CT scan to make sure it's not stroke. That's my small addition. If I see you privately, I'll probably give you some of the work they do at Doctors Hospital for TPAs, okay?
Thanks. Unfortunately, we're going to have to end the session here. Any questions for Dr. Bannister? You can see her afterwards. We'll.
Oh.
Okay, our next presentation is on the dedication to My Medicine, factors that affect medication compliance adherence in the adult hypertensive and type 2 diabetic population, a Bahamian experience.
Okay, good afternoon, everyone. My name is Dr. Danielle Strawn-Bolag, and I will be presenting on behalf of my group our study entitled Dedication to My Medication, Factors That Affect Medication Compliance and Adherence in the Adult Hypertensive and Type 2 Diabetic Population, a Bahamian Experience. Nothing to disclose, the CME code, which will be again at the end. So according to the World Health Organization, there's approximately 50% medication compliance and adherence in first world countries. In developing countries, there is a lower compliance rate. The cost of complications and care secondary to noncompliance costs the US over $200 billion per year and $19 billion in Europe. Noncompliance results in over 125,000 deaths annually in the US. Hypertension is expected to rise to 29% by 2025, and diabetes by 28% in North America. So how can we reduce these numbers? We need to understand why patients are non-compliant and place initiatives to enhance compliance. Why is this important to the Bahamas? It was estimated that we spent $17.5 million on medications and $13.5 million on surgical supplies for the budgetary year 2015-2016. And to date, there has been no study that has been published with information on medication adherence in the Bahamas. In our background literature review, the WHO gave 5 broad categories that contribute to medication adherence. And for example, one study showed that patient-related factors include things like cultural beliefs, stigmas, and socioeconomic factors included things like patients' insurance status and whether or not, if they had insurance, were they more compliant with their medications. And these are some of the things that we wanted to explore in our study. Why is it important? Why is adherence important? Because it affects morbidity and mortality. Noncompliance has a burden on healthcare system. There's a strain on the medical regimen, causes an increased drug costs and decreased productivity. So the research question that we posed, what factors affect medication compliance and adherence in the adult hypertensive and type 2 diabetic population in the Bahamas? Our objectives included to describe the socio-demographic profile, determine specific factors of non-compliance in this population, and determine the percentage of non-compliant patients. Our methodology, we included a cross-sectional study design, and everything that's in the circle was our inclusion criteria, and everything that was out is excluded. So we included patients that were 18 years or older with diabetes or hypertension, or both, from the public clinics and the accident emergency department in both Nassau and Grand Bahama. Patients who were on medical therapy for less than 3 months were excluded, and those who were admitted to the hospital with any complications related to their comorbidities within 6 months prior were also excluded. In our methodology, we used a randomized sampling approach, implied consent with the questionnaire. A minimal sample size of 384 was calculated with the Cochrane equation. And we needed a total of 427 patients to fill out questionnaires, factoring in a 10% refusal rate. So we ended up having 281 valid participants for which we extrapolated information. The instruments and procedure used were the brief medical questionnaire as well as the Mariski medication adherence scale pictured here, which are both validated questionnaires, and the Mariski scale is actually the gold standard for medication adherence. And I will be referencing it throughout the rest of the presentation. Data collection was input in SPSS. We used descriptive statistical analysis, t-test, ANOVA, and the appropriate steps were taken for possible confounding. The ethical considerations were ensuring confidentiality, secured storage, we avoided sensitive questions, and the study was of minimal risk. In our demographics, there were 68.7% of patients who were female and 92% that identified as Bahamian. In keeping with the Department of Statistics, most recent analysis of the Bahamian population demographic, the average personal income was less than $1,000 BSD per month. The median education level was high school graduate. The median age was between 50 and 64 years, and the majority of persons did not use complementary alternative medicines. This scale, in the Mariski scale, it is a range from 1 to 11. And we used an equation, the Cronbach's equation, which gave us a number of 4, meaning that 4 is the most compliant that you can be on this scale. So anything 4 or less means that you are more compliant. And because the Mariski score gave an alpha value of 0.71, it gave us an estimation of 55.5%, which is in keeping with the WHO estimation of 50%. This histogram is showing a mean Mariski score of 3 in 72% of the participants that we questioned. And of that 72%, 11.2% had perfect medication adherence. This scale is also the same, it's just another depiction, also showing that same 72% with a mean Mariski score of 3. As patients became older in the study, we noticed that the Mariski score went down, meaning that the patients were more adherent. 35.6% of those patients fell in the median age group of 50 to 64 years. So even though patients greater than 64 years had a lower Mariski score, those from the median age group fell within an adequate Mariski score level of 3. Patients who admitted to using CAM were less compliant than those who admitted to not using CAM. Patients who did not use CAM had a mean Mariski score of 2.72, as pictured here, whereas patients who did use CAM had a mean Mariski score of 4. So even though they had a mean Mariski score that still fell in the compliance range of 4 or less, those who did not use CAM were more compliant. This scale is showing the Mariski scale against the level of forgetness. We asked patients whether they forgot to take their medications, and they responded with none, a little, or a lot. 46.2% of those patients who responded none were obviously more compliant than those who responded a little or a lot, and their mean Mariski score was 2. The mean Mariski score against patients who had concern about long-term side effects. Those who had concerns about long-term side effects had a higher Mariski score than those who did not. The ones who admitted to not having concerns about long-term side effects had a mean Mariski score of 2.63. 147 participants had their medications available on request, and this represented 58.3% of the participants in the study. And the reason we want to highlight this is because when patients present to their visit, medication consolidation is important and can give an indication, or the first indication of medication compliance. And so 58.3% admitted to having their medications available upon request. We noticed that as patients had more medications, their Mariski score was lower, meaning that they were more adherent. So patients who admitted to only being on one medication had a mean Mirsky score of 3, whereas patients who admitted to being on 5 or more medications had a mean Mirsky score of 2.38. Participants were then separated into status of hypertension, diabetes, or hypertension and diabetes together. And those patients who had both hypertension and diabetes were found to be more compliant than those who had any one comorbidity alone. So 73 participants had a mean Mirsky score of 2.9, having both hypertension and diabetes. And this is just another pictorial against the frequency of patients or participants who had both hypertension and diabetes, showing a mean Mirsky score of 2.9. So discussion points. The higher the age group, the more adherent to medication. The more concerned the medication of side effects, the less medication adherence. Those persons who responded that they had no difficulty getting prescriptions refilled showed a higher level of adherence. With an increase in the prescribed medication amount, participants showed increased adherence with their drug regime. And participants with both hypertension and diabetes were the most adherent in this group study. In summary, factors that were associated with increased medication adherence: increasing age, participants with both hypertension and diabetes, patients that did not use CAM, and the amount of drugs being taken. Those associated with decreased medication adherence, difficulty remembering or the level of forgetfulness, concerns about long-term side effects, and the use of CAM. These are some of our limitations, one of which was sample population was mainly from the public sector, and it assumes that public and private sector has similar responses. These are some of our many references. Thank you for your attention.
Thank you, Dr. Strong. Are there any questions, Dr. Strong? Dr. Strong, was there any look into terms of whether older persons were living with relatives, and that contribute in terms of their economics, did that contribute with those factors looked at?
We did ask in the questionnaire how many persons were in the home, but we didn't work out the statistics of whether or not that was statistically significant in terms of whether or not they were compliant. And we actually found the opposite of what most studies are finding. Most studies are finding that as they get older, they are actually less compliant. Whereas for our age, median age group of 50 to 64, we noticed that the older they were and the more medications they were taking, the more adherent. And we think that it might be related to the fact that now they realize, oh, I'm getting old, I might die, I need to take this medication, as opposed to the younger patient who was not really, interested in being compliant.
To follow up on that, though, what was the explanation in the other papers that you reviewed? Since you found this to be a different finding, that explain why in their studies compliance went down? Was it a factor that was different here?
Well, what they concluded in some of their studies was things that he mentioned, like social support, lack of employment, that kind of thing, could have possibly contributed to the fact that their level of adherence went down the older that they went. So I guess that's, an avenue we can look into to see if social support is a factor that would affect, whether or not the patient becomes more adherent when they become older.
So they're not suggesting that we have more, or is it a suggestion that we have more social support?
Possibly.
Yeah, I know that.
It could suggest that we actually have more government support that have social support rather than actual family social support. Because remember now, a lot of the papers that we reviewed, a lot of them didn't necessarily have documentation of provided for the patients that are either older or with chronic medical disorders. So in our case, it may just be that because we have patients that are older and now eligible for NIB enrollment and access to medications on a regular basis, they can go to Lowe's, they can go to any pharmacy on the island, and various islands is that. Maybe that is what is really tipping us over into compliance as patients get older and no longer necessarily needing familial support because they actually have government social support.
Final question. Final question. Do you think that the level of education had anything to do with adherence?
We thought that it might, but there actually was no statistical significance with our study or any of the other studies that we found with education.
Thank you.
Thank you. Thank you.
The next paper is on knowledge, attitudes, and practices of primary care physicians in the management of type 2 diabetes in New Providence, the Bahamas. Please welcome Dr. Gerard DeVoe, a recent graduate of family medicine.
Good afternoon. All right, so the research I will discuss is on the knowledge, attitude, and practices of primary care physicians in the management of type 2 diabetes mellitus in New Providence, the Bahamas. I have no actual or potential conflict of interest in relation to this presentation. This is the outline of the presentation. Diabetes mellitus was estimated to affect some 9% of the world's population greater than 18 years of age. It has been accountable for some 1.5 million deaths in 2012. And in the Bahamas, diabetes mellitus is ranked 5th among the top 10 leading causes of death. The World Health Organization predicts that diabetes will be the 7th leading cause of death by the year 2030. Various search engines were used using the keywords as knowledge, attitudes, practices in primary care physicians, as well as literatures from Barbados, the World Health Organization, and Pan American Health Organization. Various studies from Pakistan, Australia, Saudi Arabia, Israel, Estonia, and Oklahoma were also reviewed. The inclusion criteria were primary care physicians who were registered under the Medical Councils of the Bahamas, who practice the management of primary care of diabetes at a primary care level. A total of 200 physicians were approached. 59 responded, giving a response rate of 29.5%. Descriptive analysis was done using the latest software, as well as chi-square testing and multivariate logistic regression analysis. Of the 59 participants, 66.1% were females. The median age was 36, the youngest being 26 years of age and the oldest 75. The number of years in practice ranged from 1 to 40 years. 62.7% of participating physicians had less than 10 years of practice experience. In terms of employment status, 89.8% were fully employed, 8.5% were part-time. And in regards to type of practice, 16.9% practiced solo, and 89.8% were in group practice. As far as full-time employment, 83.3% were from internal medicine, 88% from family medicine, and 100% from the respective other clinics, private clinics, Flamingo Gardens, Flamingo Street, South Beach, and Elizabeth Estates. In terms of accessibility to services, 81.4% claimed that they had accessibility to ophthalmology services, and 83.1% to dietitian. There was some 55.9% who claimed that they had access to counselor and psychology, and 47.5% to exercise professional, and also 59.3% to podiatrists. In terms of the use of educational guidelines, 18.6% were involved in specialized training or education for the management of type 2 diabetes mellitus. And in relation to the use of general practice guidelines in the management of diabetes, 88.1% claimed they have used them, 5.1% did not use any guidelines at all, and another 5.1% claimed that they have never heard of any such guidelines. The median number of patients with diabetes seen at clinics by participant per month was 50 for internal medicine clinic, 24.5 for family medicine clinic, 95 for Flamingo Gardens, and 150 for South Beach Clinic. In terms of the number of years physicians have been practicing at clinic, the median was 12.5 for internal medicine, 7 for Agape Family Medicine, 8 for Flamingo Gardens, and 6 for South Beach Clinic. There was no statistical significance between years of experience and overall score of knowledge. The median number of hours worked per week per clinic was 56 for internal medicine and 40 for family medicine. In terms of the number of physicians and number of nurses, the median for physicians per clinic was 21, and for nurses, for internal medicine clinic was 5, for family medicine clinic was 30, nurses 10, Flamingo Gardens Clinic was 6.5 physicians, nurses were 10.5, and for South Beach, 9 physicians and 18 nurses at South Beach Clinic. The mean knowledge, overall knowledge, was 68.7%. Greater than 62.7 scored greater than 70%. The mean knowledge score for general practitioners was 64.9, 70 for family medicine residents, 69.5 for internal medicine residents, 69.8 for family medicine residents, and 76.2 for internal medicine specialists. According to the physician attitude scale, physicians had a mean attitude of 3.97 based on a 5-point Likert scale. In terms of physician mean good practice, physicians scored 81.92 out of 100. And the mean physician's confidence level was 97.95 out of 100. In terms of problems that physicians mentioned in management of type 2 diabetes, the lack of compliance was the greatest, of some 30%. The lack of team approach followed by medications not available and access to specialty services was some 17%. There was a strong statistically significant relationship between physicians' self-reported level of confidence and 2 predictive variables, in particular in the study. 1, whether physicians were specialists or non-specialists, and 2, whether or not physicians clearly disagreed that low blood sugar reactions make tight control too risky for most people. A cross-tabulation of the reported level of confidence by whether they agreed or disagreed with this statement, stratified by whether they were specialists or non-specialists, showed that among those who were clearly confident and showed the correct response, 30.95% were non-specialists and 41.7% were specialists. The median age of all participants was in the mid-30s. The mean age of participants were similar to that of studies done in Israel, Pakistan, and Saudi. Age, neither gender, showed any influence on scores of participants. Most physicians in the study used guidelines to aid in the management of type 2 diabetes. And of those that used guidelines, more than 60% of them completed the survey in less than 25 minutes. Physicians that did not use guidelines took greater than 25 minutes to complete. The use of practice guidelines to manage patients with diabetes did not have a significant effect on the overall knowledge score of participating physicians. The participants also scored higher than anticipated. They were predicted to score around 60%, however, obtained an overall knowledge score of 69%. They also scored higher than primary care physicians in Australia and Pakistan. Physicians also did pretty well in establishing the correct fasting glucose for diagnosis of diabetes and identifying an appropriate approach to an alert patient with hypoglycemia. They're also quite aware of which anti-diabetic drug should be discontinued if a diabetic patient develops congestive heart failure. Also in identifying the different types of insulin and the composition of Novolin 7030. And also the use of beta blockers in diabetics can mask symptoms of hypoglycemic-induced tachycardia. Very few physicians knew the answer to the questions. What was the peak time of regular insulin? Or why is sliding scale insulin a less desired approach to management of type 2 diabetes? Or even, what was the recommended dose of glucagon in a severe case of hypoglycemia episode? In regards to identifying which oral anti-diabetic drug is absolutely contraindicated in renal insufficiency, physicians that practice solo scored poorly with less than 50% selecting the correct answer. The physicians in the study also scored poorly when it came to knowing the peak time of action of regular insulin, and of those that did select the correct response, the vast majority were the full-time employees. In regards to the clinic, the medical clinic, where participants were residents of internal medicine or specialists, scored the highest overall marks in the knowledge section. Physicians also generally showed a positive attitude towards patients with diabetes. However, their attitude did not have an impact on their knowledge or practices. They also demonstrated high confidence levels when it comes to managing patients with diabetes. This may be as a result of physicians feeling comfortable with managing such familiar cases as the prevalence is high, and there is a lack of endocrinologists in most cases. Also, it is made mandatory in recent that physicians complete at least 20 hours of CME credits per year in order to renew medical license. When comparing non-specialists to specialists, the latter group demonstrated a slightly higher level of confidence in their management of patients with diabetes. This may be due to their advanced level of training, which may have given them the sense of security. There was also a significant relationship between physicians' level of confidence and whether they were specialists and non-specialists. They also demonstrated high confidence levels in their management of type 2 diabetes, as well as a positive attitude towards patients with diabetes. However, their confidence level or attitude was not linear to their knowledge. A similar trend was noted in a study by Tepwanga et al., where physicians had high confidence in effective use of medication with deficits in their knowledge. As they mentioned, this can be very dangerous where physicians are overconfident with poor knowledge on management. Also, physicians in the study that used clinical guidelines did not correlate with higher scores in knowledge as seen with similar studies in Australia and Estonia, as opposed to a study done by Khan et al., which showed higher knowledge, attitude, and practice scores where physicians were using guidelines. Limitation to the study would be the low response rate may have given rise to an underrepresentation of the population. There are also limitations in generalization and inference making about the entire population to be studied. The study may have found important practical differences and relationships that may have existed, but not turned out to be statistically significant due to the p-value. Physicians that did not respond may have brought significance to the results that are in keeping with the literature. Recommendations would be to increase the power of the study by increasing the response rate of the physicians, perhaps by utilization of electronic surveys or by mailing, the use of incentives, the distribution of questionnaires at medical association conferences, the medical association conference, or by performing a census, or practically the use of a shorter questionnaire. Although primary care physicians in New Providence, the Bahamas demonstrate the right attitude towards their patients with type 2 diabetes and show high level of confidence in their management, they appear to be fairly equipped with knowledge when it comes to diagnosis and management of the disease. However, there is still room for improvement, especially in the pharmacology aspects, which can be addressed through continuing medical education and routine medical audits. Thank you.
Are there any questions for Dr. DeVoe? No questions for Dr. DeVoe? Dr. DeVoe, do you believe that given the prevalence of diabetes in the Bahamas, that this should be a topic that all primary care physicians are re-educated in? And if so, how regularly do you believe so?
Well, definitely I believe that diabetes as well as hypertension are bread and butter topics, and physicians should be evaluated every 6 months to find out whether or not they are up to standard with the management of these diseases.
Why every 6 months?
I think that it would give time after CMEs and so forth that they can have sufficient time to reflect and improve their practice. I think it should be an annual thing. I think at least annual. But the studies that I did, actually, they repeated these audits every 6 months and to see whether or not the changes improved. And they actually did improve after the initial study and presentation of the up-to-date guidelines and recommendations for management of type 2 diabetes. And it did show improvement of the physician performance.
I think you get a lot of resistance to people getting tested every 6 months.
I agree. Initially, when I chose this topic, I was told that I would get a lot of resistance from physicians actually performing.
In the context of the study, that's one thing, but in the context of evaluating people's
I agree, but
to make sure that they're safely practicing, it's a different thing.
I agree, but I think it's mandatory moving forward if you want to improve the standard of care. And I think, I mean, in any event, the clinical audits are recommended in any institution, especially if you want to improve.
And finally, what was the greatest weakness in terms of knowledge?
The pharmacological aspect of it. I think physicians are not aware of all the medications that are available for the management of diabetes, as well as their mode of action or the complications or the side effects. I think that was one of the greatest weaknesses in the knowledge.
Thank you, Dr. Duval.